friends, this is Shriti Joshi and today I am going to talk about elbow joint management. What is the functional use of the elbow? Especially we need for mobility and functional range of motion. Elbow flexion 130 degree we need, elbow extension 10 to 15 degree we need for almost activity in daily living, supination 50 degree and pronation 50 degree for ADL. Muscle control and muscle coordination between shoulder and elbow is also needed for functional activities like two joint muscles is biceps and triceps we need for activities in daily living like eating and we have if we are taking some thing from the overhead or if we are lifting something from down we need these muscles. Let's see mobilization for humeroulnar joint. So if we are mobilizing humeroulnar joint, so either patient have a flexion problem or extension restriction. So if patient is not able to do flexion, so we can use distal scoop motion. For in this diagram you guys can notice that patient position is in supine, then we have to apply distraction force to the joint at 45 degree angle to the ulna and maintain it. While maintaining this force, we have to apply force in distal direction along the long axis of ulna while using the scoop motion, so that will help you to improve your flexion. So for humeroulnar flexion improvement, you can apply distal glide and the another glide like the second one is lateral or radial glide. In this for this we can keep the patient in sideline position and we have to apply the lateral glide on ulna and radius, and shoulder should be in external rotation position with forearm supination and apply the force to the proximal head, so that will help you for flexion of your humeroulnar joint. If we applying glide for extension, so for that you guys can notice that for extension we can give a proximal glide or medial or ulnar glide. In this patient position is in supine position and we have to stabilize the humerus and apply the medial word force toward the head of the radius that will help you to improve your extension. If we are treating the humeroradial joint, so for that patient may have a flexion problem or extension restriction. So for that patient we have to keep the patient in supine or sitting position with elbow extended and supinated position. In this diagram we can see that the patient is in supine, elbow extended and supination position. For this we have to stabilize the humerus and mobilize the head of radius. If we are giving flexion, so flexion, just remember anterior or volar glide. So you have to give in the anterior direction and or the volar direction glide. Just you have to stabilize the humerus and mobilize the head of the radius in anterior direction. If extension restriction is there, stabilize the humerus, give dorsal or posteriorward force, so that will improve your humeroradial extension. Let's see proximal radioulnar joint mobilization. So for that we have to keep patient is in supine position or sitting position. We have to stabilize ulna and mobilize here we are stabilizing the ulna and mobilizing the head of radius. So if we want to improve supination, we have to give anterior or volar glide on proximal radioulnar joint on the head of radius. If we want to improve pronation, so for that we are going to give posterior or dorsalward glide for your pronation. So we have to give posterior dorsal glide on the head of the radius and stabilize the ulna. That will improve your pronation at proximal radioulnar joint. Let's see management for tennis elbow. First phase is maximum protection phase. So in this phase patient have complaint or patient have presentation like pain in activities in daily living like lifting, holding objects, gripping, turning knobs or typing or writing. Range of motion limitation, especially extension is limited. Here we can this diagram we can see that this is tennis elbow, because patient is having repetitive gripping activities, so that cause the pain with wrist and finger flexion, and middle and finger extension with the elbow extension. Tenderness is present at the lateral epicondyle proximal to extensor carpi radialis brevis muscle. Here they can have pain, and as this patient is in maximum protection phase, so we have to provide rest and anti-inflammatory medication. Patient can apply ice also to avoid. We have to educate the patient to avoid pain provoking activities like lifting heavy object, repetitive forearm pronation, supination. Start with active assisted range of motion to active range of motion exercise, pain-free isometrics of wrist extensors and supinator and wrist deviators. We have to start a shoulder range of motion activities also. Let's see moderate protection phase management. In moderate protection phase, patient have pain, but that will reduce with the rest. Little pain with the elbow with active motion, and mild limitation of ulnar deviation and wrist flexion. Affected side strength is decreased, and grip strength is also decreased for this patient. Let's check the intervention for moderate protection phase. We have to apply deep hitting modalities before the exercise and ice after the exercise. Can also apply cross fiber massage to wrist extensors, and we have to give advice for modifying the activity in daily living which causing them pain. We have to start pain free isometrics, especially the wrist extensor should be in shortened position like elbow flexion 90 degree, forearm supination, and we have to start isometrics for supinators and pronators, especially in pain free ranges, because if they have pain and if they are doing repetitive activity, that may aggravate their symptoms. So we have to do in pain free range. Movement with mobilization is we can give for proximal radioulnar joint, and we have to teach them self stretching of wrist extensor and continue with the active range of motion, and this is the moderate protection phase, so we have to start resisted range of motion exercise with elastic resistance. For precaution, for progressive resistance exercise, if pain is absent with active range of motion, start the resisted range of motion exercise within 1 to 2 weeks, and we have to start with the low intensity grip strengthening exercise first. Lastly, patient is determining to the functional phase, so patient presentation is same as moderate protection phase. Exercise, we have to start strengthening exercise, and ergonomic modification is necessary, like forearm should rest at the keyboard, and they have to adjust their computer so they should not feel pain on the lateral epicondyle, and large diameter grips for the racket and tools. Use a counter strap distal to the lateral epicondyle, and start with the plyometric exercise. Use short to long head racket that will help them for activity in daily living and sports, and start sports specific training with very slow speed, and we have to increase it gradually. Let's see golfer's elbow management. First, we are going to start with maximum protection phase. Patient presentation, they have pain in the middle aspect of the elbow. Painful functional activities, like if they are golf players, this is the picture of the golf player Lorena. So in this, she is playing golf, and repetitive gripping activities like throwing, so that is causing her pain. That may cause the pain in patient. And casting, if patient is doing casting with fishing rod, so that will also cause the pain. Pain increase with resisted wrist flexion and radial deviation and forearm pronation plus elbow extension. Patient is having limited elbow extension. Tenderness is present over the medial epicondyle near the flexor carpi radialis muscle, aggravated by the passive end range wrist extension and forearm supination. Intervention for this phase: rest and anti-inflammatory medication, especially static splint and ice we can apply for this patient. Ask patient to avoid pain provoking activities and start with active assisted range of motion exercise for wrist, forearm and elbow, which is pain-free range of motion. Let's see golfer elbow management for moderate protection phase. Patient presentation pain is reduced as compared to maximum protection phase. Limited supination and wrist extension. Grip strength is reduced and decreased strength and endurance of elbow and forearm musculatures. So what we are going to do for this kind of case, we have to start with deep hitting modalities before we start exercise, so their pain should be reduced and their range of motion should be more, and ice after the exercise. Cross fiber massage we can provide for this patient, and start with pain-free isometric exercise, especially wrist flexors, and pain-free passive range of motion for wrist extensors. And we have to progress this flexor exercise, and especially in lengthened position. Self-stretching of pronator muscles and wrist flexor muscle we have to teach them, and start with resisted range of motion exercise. For golfer's elbow management, especially in functional phase, we have to start with progressive resisted exercise, and that should be in slow speed, and we have to increase gradually. Start sport specific training. Here we can use counter force strap also. We have to keep distal to the medial epicondyle, and ergonomic modification like golf swing, throwing, pitching technique modification, and plyometric train. Let's see ulnar collateral ligament sprain. Patient presentation, they have if mechanism of injury, valgus or external force, seen in throwers and baseball pitchers. This can also be seen in tennis player. A patient presentation, medial elbow pain will be there. So for this patient, if it is in acute phase, we can increase range of motion, promote healing of medial collateral ligament, and slow down the muscular atrophy. Ice and compression can be given to decrease pain and inflammation, and exercise should be done in mid-range and pain-free motion. So for increased range of motion, we have to splint in non-painful position like 20 to 90 degree, and pain-free active assisted range of motion we can start, and passive range of motion of elbow and wrist. First we have to start with passive, and then we can start with active assisted ROM. We can stretch and strengthen the flexor carpi radial ulnaris, flexor digitorum superficialis, and pronator teres muscle, and isometrics for forearm flexors, ulnar deviators and pronators. Let's see management for subacute phase of ulnar collateral ligament sprain. We have to increase range of motion 0 to 135 degrees, so 10 degrees per week we can increase. Start with concentric exercise, for example wrist curls and wrist extension, progressive resisted exercise, supination, pronation, and biceps, triceps progressive resisted exercise we can provide for this patient in subacute phase. And the last phase, advanced to chronic phase, our main goal is to reach full range of motion, no pain, no tenderness, and strength should be 4 out of 5 for elbow flexors and extensors. We have to do exercise to improve strength, power, endurance, and to improve neuromuscular control. So we can start with TheraBand exercise for biceps, triceps, supination, pronation, and wrist flexion and extensors. And last one is return to throwing phase criteria. So it should start after the 3 month, and there should not be any pain, or there should be full range of motion, no ligament laxity, and their isokinetic testing should be good. So in this phase we can provide a plyometric training for this patient and sport specific training. Let's see pulled elbow or nursemaid elbow management. Patient presentation, pain at a proximal lateral aspect of the elbow, sudden forceful pull head of the radius with wrist flexion and elbow extended position. Patient is not able to use affected arm, and supination is especially restricted, and patient whole hand in pronation and wrist flexion. And for this patient, intervention, thrust manipulation at the proximal humeroradial joint, and start active range of motion of wrist and forearm. Let's see management for fractures. So if patient is having supracondylar fractures of the humerus, so there might be displaced or non-displaced. So for displaced fracture, close reduction and immobilization cast for 3 weeks, and for non-displaced, immobilization in a simple sling for shoulder immobilizer, and for elbow flexed for 3 weeks. For this patient, we have to start active range of motion exercise and effort to regain the full extension and strengthening of biceps and triceps. For non-displaced and minimal displaced olecranon fracture management, we have immobilize in posterior splint or elbow immobilizer with elbow flexion at 90 degree. Exercise, we have to give them pronation and supination. Start with within 2 to 3 days, and pain-free flexion and extension motion begins after 2 weeks. We have to give them range of motion exercise and avoid full flexion up to 2 months and resistance exercise up to 3 months. Protected immobilization should be continued until the evidence of union up to 6 weeks. Let's see Olecranon fracture management, displaced fracture management. If it is displaced, so open reduction internal fixation is needed. That is done by the surgeon, and excision of the bone fragments with repair of extensor mechanism. Management for ectopic ossification, start with active range of motion exercise. Avoid passive range of motion exercise that may damage the soft tissue, and flexion and extension are limited, so patient is issue dynamic flexion splint and dynamic extension splint, and in instruction we have to give how to use them and active range of assisted range of motion exercise, and we can provide for this patient.
Thanks for watching, and for future videos don't forget to subscribe. If you have any doubts related to topics in physical therapy exams, please let me know in my comment section so I can make a series of the videos on that. Till that time, stay positive. Bye bye.